Ashish Jha, Associate Professor of Cardiology at Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow, will be speaking for the next 10 minutes.
Yeah, good afternoon, everyone. We all know that heart failure is a common problem and its prevalence is increasing. Why is heart failure important? Because it is associated with high morbidity and mortality, poor quality of life, and frequent hospitalization. For management purposes, heart failure is divided into three categories: preserved EF, mildly reduced EF, and reduced EF. Those patients whose EF is less than or equal to 40%, they constitute reduced EF patient. I'll be talking today about this subset of patients only. So when we treat a heart failure patient, our aims are to improve their symptoms, functional capacity, and quality of life, to improve their survival, and to reduce their hospitalization. We can achieve it by pharmacological measures, device-based therapies, or non-pharmacological general measures. So whenever a patient with heart failure with reduced EF presents to us in OPD, what should we do? The first step is to confirm the diagnosis based upon review of symptoms, signs, and 2D echo. We have to determine etiology because it will decide the further course of action. Specific therapy will be decided upon what is the cause for heart failure, and the outcome will also be guided by that. We have to record and document their baseline blood pressure, pulse rate, volume status, NYHA functional class, LVEF at baseline, comorbid condition, and concomitant medications that he is taking. All these factors are going to matter in management. Their baseline investigation, a set of tests are recommended, which we all know. All of them should, from the first visit itself, should be advised about taking salt-restricted diet, fluid restriction. Exercise has a very important role for those patients who are stable, as it has been shown to reduce heart failure hospitalization and improve their quality of life. There is a class 1 indication for them. Even for those patients who have multiple comorbidities, who are old or frail, for them also a supervised exercise-based cardiac rehabilitation program has been shown to be useful. There is a class 2A recommendation for that. For symptomatic management, the loop diuretics are the cornerstone. They help by reducing congestion, improving symptoms, improving exercise capacity of these patients. The principle is that we have to achieve and maintain euvolemia at the lowest possible dose of loop diuretics. Now, the backbone of the pharmacotherapy for heart failure with reduced EF is 4 medications which have been unequivocally proven by RCTs to be useful in reducing their mortality, improving their symptoms, and hospitalization. These 4 are called as Fantastic 4. They include ACE inhibitor or ARNI, mineralocorticoid receptor antagonists, beta blockers, and SGLT2 inhibitors. Any other intervention, be it pharmacological, be it device-based or surgery, whatever has been shown in this slide, are all secondary to this. First, we should put these patients on these 4. Now, how to put these patients on 4? The first 2 medications to be added for a patient are beta blockers and ARNI. For beta blockers, we know there is evidence for 3 drugs: carvedilol, metoprolol succinate, and bisoprolol. Amongst ARNI and ACE inhibitors, the ACC guidelines clearly recommend that we should prefer ARNI. ACE inhibitor or ARB should be started only if the patient has a contraindication to or intolerance or inaccessibility to ARNI due to any issue, including cost. We should be aware what are the contraindication for ARNI. We should be careful not to start ARNI within 36 hours of giving ACE inhibitor. There are several trials available which have for upfront start of ARNI in these patients. We should be careful to start at a lower dose in those patients who are treatment naive, who have never received any ACE inhibitor or who are coming for the first time. The starting dose should be 50 milligram twice daily in them. Even those patients whose BP is borderline, they should also receive the same dose. Otherwise, starting dose is 100 milligram twice daily. This table shows all the drugs which are commonly used for heart failure with reduced EF patients, their starting dose as well as target dose. What is important is that we should always strive to achieve the target dose as that is the dose at which best outcomes are seen. We should continue up titration even if the patient has become totally asymptomatic and his EF has improved. The principles are that we start with low dose of a drug and gradually up titrate. How gradual? Usually we call them up after every 2 weeks and up titrate the medications based upon their vitals and renal functions and electrolytes. For those patients who are elderly, frail, who have deranged renal functions or low BP, this up titration can be more gradual once in 4 weeks. The aim is to achieve the target dose of these 4 medications within next 3 to 6 months. The studies have clearly shown that simultaneous initiation at a lower dose is much better than sequential initiation and achieving a higher dose, one by one. The first two drugs to be added, ideally in the first visit itself, should be ARNI and beta blockers. They should be started together at a low dose. If a patient has low BP or is congested or decompensated, then depending upon what is the predominant symptoms, if congestion is predominant, then ARNI should be preferred, if a single agent has to be added. If there is no congestion and tachycardia is prominent, then beta blocker should be the first one. If patient is congested and has low BP, then probably ARNI may not be safe and ACE inhibitor can be the first choice. Once our patient has been put on low dose of combination of ARNI and beta and he is tolerating, his BP is stable and RFT is not deranged, then we should consider adding mineralocorticoid receptor antagonists and SGLT2 inhibitors. Ideally, patient should be added on all the 4 class of drugs within first 1 month, because the benefits, the maximum amount of benefits that is derived from these drugs appear within 1 month of initiation. So we should not deprive patient from this early benefits. Initiation and up titration of SGLT2 inhibitors and aldosterone antagonists is very simple, because there is only single dose for SGLT2 inhibitors and there is only one step up titration for aldosterone antagonist. What is important is that we should avoid these drugs in patients who have advanced renal failure. Before initiating, the loop diuretic should be reduced, and especially with mineralocorticoid receptor antagonist, we should monitor creatinine potassium very carefully. This table shows how frequently we should do it. Now, what is the advantage of giving all these drugs? This is a very interesting paper published in Lancet 2020, which evaluated comprehensive therapy, including ARNI, mineralocorticoid receptor antagonist and SGLT2 inhibitor versus conventional therapy that we usually use, including ACE inhibitor and beta blocker. It was seen that patients who were on comprehensive therapy, they had more than 50% reduction in cardiovascular death, heart failure hospitalization, as well as all-cause mortality as compared to the conventional ACE inhibitor and beta blocker therapy alone. Not only this, their survival, event-free survival was also significantly prolonged. If a patient was started on comprehensive therapy at 55 years of age, they were likely to survive for 8.3 years more as compared to only ACE inhibitor and beta blocker. Even if they are started at 65 years of age, they are likely to survive for 6.3 years more. So that is the importance of starting this drug early and all of them together. Number needed to treat, to prevent one event of heart failure, hospitalization or cardiovascular death was only 4 to 6 for a treatment duration of 3 years. So there is a phenomenal benefit of starting all 4. Despite this knowledge base, the practice is, this is not being incorporated into practice. Even the US data of CHAMP heart failure registry, which evaluated OPD prescription of stable heart failure with reduced EF patients in US, it showed that of all the patients who were eligible for these 3 class of drugs, 86% of those eligible patients were not receiving ARNI, 33% of patients were not receiving beta blockers, 66% were not on any dose of mineralocorticoid receptor antagonist. Even those who were prescribed these medications, very few of them were receiving the target dose. And only 1% in US received all the 3 drugs at target dose. So there is a big gap between evidence and practice, which should be reduced. So if a person has been put on all 4 first-line medication and symptoms still persist, then we should add second-line medication, which include ivabradine. We know ivabradine has a role for those patients who continue to have symptoms and LVEF less than or equal to 35%, and whose baseline heart rate is more than 70 despite being on maximal tolerated dose of beta blockers. It helps by reducing heart failure hospitalization in these patients. Isosorbide dinitrate and hydrogen combination is also useful, particularly in black patients and in those patients who have severe symptoms, class 3, class 4 symptoms, and who are not able to tolerate ACE inhibitors. If symptoms still persist after adding second-line drugs also, then third-line medications like vericiguat and digoxin can be added. There is a class 2B indication for both as they reduce hospitalization. Vericiguat is not available in our country. This is the usual OPD prescription of stable heart failure patient, how it should be. It should include a low dose of loop diuretic, the target dose of Fantastic 4, and second-line medication if it is required. What is important is once the patient has reached this stage, when he's already on target dose of medications, we need not follow up them very closely. They may come up for follow-up once in 3 to 6 months also. Echo should be done only if there is a change in clinical status of the patient. One of important issue is adherence, because we prescribe so many medications. If patients don't take, even in RCTs, 20 to 50% patients were not taking their medications. We can improve this adherence by educating the patients using combination pills, generic medications, and monitoring for adherence. One important thing is heart failure. Program-based, team-based approach is superior to individual managing the heart failure patients, and there is a class 1 recommendation for constitution of heart failure team. What about those patients who have recovered their EF? The trial has shown that those patients who have recovered, if we stop treatment in them, their LVEF worsens. 40% of them develop recurrence of heart failure within 6 months. So treatment should be continued.
Sorry for the interruption, Dr. Jha. You have run out of time, so we'll have to move on to the next presentation.